No, we all do. We all do. He's all good.
Yeah, there we go.
Okay. What time do you want to start?
Start now. I always go for 3 parts.
Okay, well done for all of you who came by 3 past. We're going to talk about strokes and stuff. I think we split it into like localization of strokes and a little bit of the basic year 2 neuro revision. And then we're going to take it more towards the clinical investigation and management with a few cases dribbled in and some SBAs at the end because we know you love SBAs. So first of all, this is a general thing, not specifically with strokes, but a neuro reg taught me this and it like saved me for the rest of my placement. Always, always, always in your history, ask about the timing or the onset of someone's symptoms. Okay, and hopefully my terrible drawings and graph will help illustrate this. So if someone's course of disease or symptoms comes really, really suddenly, and then resolves really, really quickly afterwards, what kind of causes are we thinking? Feel free to whack in the chat. So like what sort of neuro conditions come really quickly and then go away really quickly? There's 2 like really main ones that I'm thinking of here. If you're stuck, try and use Anush's surgical sip. Really good, really good. TIA from all 3 of you. Well done. Yes, that's the vascular. I was going to say, think etiology with the surgical sieve. So vascular is a really, really quick one. There's another one. I will give you like 5 more seconds to try and think it up. If not, I'll move on. Neuro happens really quickly and then resolves and settles completely quite quickly, provided it's not status something. I will move on. It is electrical things as well. So seizures, they typically come like that and then they resolve provided it's not status epilepticus. Okay, how about this one? So you've got fast onset, but it's a much slower recovery. Any ideas? I'll give you a hint. We're going to spend about 50 minutes talking about it today. Yeah, well done, Hannah. Strokes, really good. So that's the main one. So again, really fast onset. It's a vascular thing again, but because you've got permanent damage, you don't have that fast recovery like you do in a TIA. This one, so you've got slow gradual onset from hours to days. It's typically infective. So if you're thinking meningitis or encephalitis, or if it's a headaches thing, it's usually indicative of a primary headache. And then this onset from days to months, a bit more of a slower onset, suggests metabolic, so toxin mediated, inflammatory. So if you're thinking Guillain-Barré, or things like neoplastic as well. So if you've got tumours, that's more of a gradual process. But it's funny because this one question can really help narrow down your differentials very, very quickly. So hopefully you can carry that with the rest of your placements. But yes, let's go on to strokes. Can anyone in like 1 sentence give me a sort of summary of what a stroke is? It doesn't have to be textbook definition. It can just be how you remember it or what it means to you. So I think we've all heard of it, but how do we define it? I think people always struggle with the definition questions because we all know what it is, but we don't know how to describe it properly. So let's move on. I think, put simply, it's when you get poor blood flow to the brain, causing specifically cell death, and they call that infarction. Okay, and it's important that it's cell death because it helps differentiate from something else, which we'll allude to in a second. Importantly, the death of these neurons in the brain gives you a rapid neurological deficit, which is why we talked about that fast onset. And the specific symptoms that you get depending on the artery and therefore the region of the brain that is affected. You have what is the difference, before we do that, between a stroke and a TIA? So we've established the onset is slightly different. You have a much faster recovery in a TIA, but what's happening on a cellular level? What's different? There's no cell death. Fantastic, Nivetha. Really, really good. Yeah. So what happens in TIA is you have ischemia. So the cells are deprived of oxygen because of, a clot's come off, but it's broken away. And so cells are deprived of oxygen. They're not working. You get that those symptoms, but it resolves. The cells aren't dead, and therefore the symptoms resolve very quickly. But yeah, really, really good job. There's no cell death. So that's ischemia, not infarction. There are, broadly speaking, two types of stroke. Can anyone give me one of them, perhaps? And as a bonus, if you know the two, which one's more common? Ischemic and hemorrhagic. Well done, registry. Can anyone tell me? Okay, well done, Hannah. Very good. Good teamwork between you. So exactly, you've got ischemic and hemorrhagic strokes, and ischemic strokes make up 80% of them and are the ones that we can manage more effectively. So hemorrhagic basically means that the areas are deprived of oxygen or blood because there's bleeding into it and you've not got that supply. In ischemia, there's just something blocking the artery. Most common. What is the most common cause of a hemorrhagic stroke, or what sort of pathologies are very linked to hemorrhagic strokes? If you guys have done renal, think polycystic kidney disease.
Why
Go ahead,
though?
Patrick.
Hello?
Hello?
Oh, you can hear me.
Yes, I can. Do you happen to know what the most common cause of a hemorrhagic stroke is?
Subarachnoid, one of those epidural.
Yeah, good. So you can get subarachnoid
Cold.
hemorrhages, but they often predisposed by berry aneurysms because they're more likely to erupt. Good. So we'll do a bit of second year recap. This is a very nice diagram of the lobes of the brain, and broadly speaking, they have their own functions. To save quizzing you, I've put them here. So the frontal lobe is involved in lots of different things, behavior, higher order thinking, but the prefrontal cortex is involved in movement. So that's a really big thing there. The parietal lobe is more involved in sensation. You've got the somatosensory cortex there, but it also carries your optic radiation for vision. So temporal lobe also does vision. It covers the superior quadrants via the optic radiation. It also does memory, hearing, and then the occipital at the back do your vision. I've got bad internet, so let me know if things are going wrong. Anush, Izzy, just pop on and let me know that things aren't working.
I thought it was my internet, to be honest.
Okay. I can try and move to a better router. Oh no, I'm on the best router. Crap. Okay. It also helps to know a little bit about the arteries. I think it's easy knowing like the regions done by what. But I think knowing how they come off and contribute to this so-called circle of Willis is really, really helpful. So you've got sort of two main arteries that contribute to this circle of Willis. You've got the internal carotid and then you've got the vertebral artery. The internal carotid artery gives branches, the middle cerebral artery, which is the biggest one, and then the anterior cerebral artery, and your posterior cerebral artery comes from the basilar artery, which runs up, and that in turn arises from the vertebral artery. So internal carotid, vertebral artery, they both give off their branches. The internal carotid gives you the anterior and the middle. The middle's the chunkiest. It supplies most of the brain. And then the vertebral artery gives you the basilar, and then the basilar gives off the posterior cerebral arteries. The reason why we've evolved to have this circle of Willis is if we have a clot in one of them, the circle manages to supply a lot of the rest. So it minimizes, in theory, the impact of losing one. This is really, really, really helpful to learn and important, imperative, in fact. The regions of the brain that are supplied by each artery. It's confusing because unfortunately it's not as simple as saying it's confusing because the anterior cerebral artery doesn't supply the anterior of the brain, and the middle doesn't supply the middle, and the posterior doesn't supply that. Broadly speaking, it does, but the anterior and the middle cerebral artery both supply the frontal and the parietal lobes. What's different is the middle cerebral artery supplies the lateral side of the brain, like these bits on the outside, and then the anterior cerebral artery supplies the medial. So you can see on this diagram, the medial, if you chop the brain in half, the middle bit is supplied by the anterior, but the lateral bits, the bits on the outside, is supplied by the middle cerebral artery. Unfortunately, yeah, it's weird because you think middle and you think lateral, but you'll learn. But yeah, importantly, remember that the MCA covers the lateral frontal lobe and temporal and parietal lobes. And then, now that we know that, it can help us with the lateralization of stroke symptoms. And there's 3 diagrams that I think are really useful to learn, and that helps us know all of the symptoms. So we'll start with this one, the most hated, weird monstrosity from year 2, the homunculus. But basically, it suggests that medial cortex is more of the legs, the lower limb. Then as you go lateral, you get the upper limb, the hands, and then the face. Okay, so what does that suggest for motor symptoms and somatosensory symptoms as well, for the anterior cerebral and the middle cerebral artery? What are you getting for an anterior cerebral artery? Which part of your body is going to be affected?
An ACA stroke's more likely to affect the legs over the arms.
Lovely, thanks for that, Jordan. So an ACA is really, because it supplies the medial side of the brain, but it's only like a tiny sliver of the medial. The MCA still covers most of the rest. So you're absolutely right that the anterior cerebral artery is mostly the legs, really, and then you tend to think of the MCA as being more of the arms and the face, because, like I said, it's more of the chunky one. I said that on purpose, Anish. The next diagram that's really useful is this one. So Broca's and Wernicke's area mentioned to death in year 2, and they're really useful for what, guys? What do we use those for?
They're both speech areas.
Yeah, really, really good. So yes, well done, all of you, the 3 of you. So Broca's area is mostly for the sort of, I always think of it as like the mechanics of speech, actually getting the words out, and Wernicke's is more for the processing of language and using that. So those are found on the dominant hemisphere, and they're covered by the MCA as well. So you get aphasias if those are lost. If it's non-dominant, so if the non-dominant side is affected, you get lots of different symptoms, but hemispatial neglect is one of them, which is when you, like, if you draw a flower, you miss the left-hand side of the flower. Which side of our brain is usually dominant? Left. Very, very good. Yeah, so most of us are right-handed, so 90% of right-handed people have the left side dominant. The few people who are left-handed, still 70% of them have the left side dominant, so it's usually safe enough to say left, but if they're left-handed, you might want to inquire. And the final diagram that's really helpful is the horrible visual pathways, but let's keep it simple. We said that the MCA covers the temporal and the parietal lobes, which carry the optic radiations, and that's when the visual pathways have already crossed. So you've got the sides that's just all blue and all red, and that means you emit half of your visual field. So you get a homonymous hemianopia, and it's contralateral because it's crossed. And then PCA gives you something similar, but importantly, you get a contralateral homonymous hemianopia, but it has macular sparing, and we'll go into that later. Actually, we'll go into it now. Why is this the case? Why do we get macular sparing? It's a very.
I wonder who remembers what the macula is.
Oh, that's a good point. Thank you. So the macula is like the central vision, the best color vision and the most detailed, but it's like the center of the retina is your macula. I haven't done opthal, so I could well be wrong, but yeah. So macular sparing, you get it because let me put these arrows on. So I've put arrows here where which bits of the visual pathway are affected. So the MCA affects the optic radiations, whereas the PCA actually affects specifically the visual cortex. So whilst the visual cortex still receives the same thing, the visual cortex receives a dual supply from both the MCA and the PCA. So even though you lose the PCA, the visual cortex still gets blood supply, which means or the macular bit of the visual cortex still gets some blood supply from the MCA, so that still survives. So they basically see the middle bits of their vision, but everything around it they can't. And you get some other visual cortex signs, so agnosia, prosopagnosia, when you can't recognize people's faces, cortical blindness only if you have bilateral PCA infarcts, which is quite rare. Let's move on. A quick one on brainstem strokes. They're always really complex and confusing, and they're probably the most hated bits of strokes. In real medicine as well, they're the hardest to detect because they're not quite so obvious. But you should always consider it if you have these crossed sensory and motor findings. So if they've got weakness on the right side, but weakness on the left side of their face, always think brainstem strokes when you do that. I have a 3-step plan to help you with brainstem strokes. If you remember these 3 facts, then you should be able to navigate your way around most brainstem questions. Number 1, the order of the brainstem. Midbrain, pons, medulla, MPM. The M's are never together, pons is in the middle, and I always think midbrain, brain, so it's probably closer to the real bit of brain, so it's at the top. So midbrain, pons, medulla. Step 2, know the cranial nerves that are located in which bit of the brainstem, and it falls in quite a nice order. So the midbrain's got 3 and 4, pons has 5 to 8, and medulla has basically the rest. Okay, so the most important ones remembering is 5 to 8 are in the pons, and 9 to 12 are in the medulla. My final thing for you to remember is which artery supplies what. So this is helped if you remember point 1, because I always, for some reason, even though anterior and posterior do not mean above and below, I think anterior, which is first, is above the posterior, which is below. And the one that's above is going to be the pons, and then medulla is going to be the one that's below. So you have the anterior inferior cerebellar artery, which supplies the one that's above, the pons, and the posterior inferior cerebellar artery that supplies the one that's below, which is the medulla. Okay, so if we remember these 3 things, got fireworks in the background, you should be able to answer most questions about brainstems. Okay, so the main ones I think they test you on are these ones: lateral medullary syndrome, which is also known as Wallenberg's, and lateral pontine syndrome. Okay, lateral medullary syndromes are by far the most common. Okay, so they're probably the highest yield, but because of the different geography of things, they sometimes like to contrast it with lateral pontine syndrome. So first questions first: which artery is going to be affected that causes lateral medullary syndrome? Thinking the order of the brainstem and anterior versus posterior inferior cerebellar artery. Very good. Yeah, pica. So lateral medullary syndrome is the one that's the bottom, because you've got midbrain, pons, medulla, and the bottom one refers to the posterior, so posterior inferior cerebellar artery. Fantastic. So lateral pontine syndrome, conversely, will be caused by stroke in an ACA. Good. Because they're quite close together, there's lots of shared features. So you can remember, oh, I've got them here. In green are basically like the shared features. So both of them will have these signs. You'll have the crossed motor because you have the pyramidal tracts affected, and the facial things because you'll affect the facial nerve and there's no decussation. You'll lose the sympathetic neurons that travel down the brainstem, so you get Horner syndrome, which is the stuff you'll see in the eye, the meiosis, the thingamabob, the triad. And then you'll have ipsilateral, vestibular, and cerebellar signs. So when the vestibular is affected, they'll feel nauseous, they'll get nystagmus. If cerebellar's signs, you'll get ataxia, you'll get fast finger pointing if you do an upper limb examination. And they'll be common in both. The things that are different are to do with their cranial nerves, which is why it's useful to remember the differentiation. So what cranial nerves are going to be in the medulla and so affected by affected in lateral medullary syndrome? So 5 to 8, 9 to 12. Okay, we've got a split. Well done for the 50-50. Well, actually, you didn't go for 1 to 3, so well done both of you. Medullary. So we're thinking going down, midbrain, pons, medulla. Medulla's at the bottom, so it's going to be the lower ones. So 9 to 12 is the correct answer. Well done, Jordan. But well done for giving it a go, Rebecca. And lateral pontine syndrome is going to be 5 to 8. So you'll get signs from those. So in lateral medullary syndrome, 9 and 10 are the main ones. So you'll get dysphagia, dysarthria, because they can't use their pharynx and communicate that well. In lateral pontine syndrome, you'll get 6 to 8 of the most common ones. You get diplopia, because you'll get abducens weakness. You'll get facial droopiness, and sometimes you get deafness. More common in SBA land, so still helpful to know. Okay, so hopefully you can differentiate between the 2 most common types of brainstem strokes. Right, let's do a case study. You guys are my collective doctors, and Issi will be your mouth and will ask all the questions of the history. I will be James, a 22-year-old male who presents to ED after noticing some strange weakness. Please take his history. I have his ops there for you to have a think about. I also have some questions to consider for you to maybe guide your history taking. So fire all of your questions, and I will now be James, a 22-year-old male.
So hi James, I'm Issi, I'm one of the F1s, and I've just come to chat to you about what's been going on. So I was just wondering, is there any weakness in any of your limbs at the moment or your face that you've noticed?
Yeah. I can't lift my hand.
Your right one. Okay. And are you having difficulty speaking?
You're not meant to be asking the questions, is it?
Sorry, also a massive firework just went off outside my house. How long has the weakness lasted, and when did you first notice it?
Ten hours.
Okay, 10 hours ago. Has this ever happened before?
No.
Did it come on suddenly, this weakness?
Yes.
Okay. And have you got any changes to your vision?
I don't think so.
Okay. Did your speech get affected at the same time as your arm?
Yes. I don't know what's happening.
Any changes to your sensation anywhere? So any tingling, numbness, or burning?
None.
And have you had a head injury?
No.
Okay.
Cool. We will move on, but all excellent questions. Really, really, really good questions about localization, timing on onset after we went through the sort of fast onset, slow onset kind of stuff. Really good. Good for picking up on the speech. Well done to ask about visual problems and sensation. And good, Nivetha, to ask about injury to heads because you're thinking about other things aside from strokes. Can anyone name the speech problem that I was trying to recreate?
That was good acting, by the way.
Thank you. I watched so many YouTube videos. Really good, Charmaine. Yeah, Broca's aphasia. So that leads me on very nicely to the aphasias that you'll get. So Broca's aphasia, we talked about Broca's aphasia. There's also Wernicke's aphasia, and there's a third one called conductive aphasia. these are other names that you'll find them for. It's really confusing because they have 3 separate names and they get referred to differently in textbooks and such. So just try and remember all 3. And it makes sense once you understand which one's which. So Broca's aphasia. Oh, don't know why that happened. Like I said, because Broca's is more to do the motor movements of speech. They have very short utterances because every word is a struggle to get through. They often, for some reason, use very limited vocabulary. So they don't use, I was feeling very fine, so therefore I went to the shops. It's feeling fine, go shops. So you still got the content, but the grammar between them isn't quite right. And there's a clumsy formation of sounds. So they're working really, really hard. And sometimes instead of saying spoon, for example, they say spoot because they just got the sound wrong. Wernicke's aphasia is more to do with processing of language and understanding. So they can speak absolutely fine, just like I'm doing right now, but the words will be completely inappropriate. So it'll be like banana spoon, high apple hang glider. And it's really difficult for me to do right now. But they call it a word salad because it's like they've just taken random words out of the dictionary and just shoved it in one sentence. They often have impaired comprehension as well, so they might struggle to read and write, whereas in Broca's aphasia, sometimes if they can't communicate with you, they'll try and write it down. A conductive aphasia, if you can remember back to your second year, is when you have sort of ischemia to the arcuate fasciculus, which is the neurons that connect Wernicke's to Broca's area. So because that's affected, what happens is they can speak and understand well enough because Broca's and Wernicke's are still working, but they can't link the two, so they can't repeat words or phrases they've heard. Oh, lovely bit of house. Fantastic. Thanks, Nush. But yeah, those are the 3 aphasias that you're probably most likely to see. Sometimes it's difficult clinically to tell between them because you've got people with dysarthria, which is when they struggle with their mouth movements. So it sounds like an aphasia, but it's not because of a neurological thing. It's because, again, mechanically, they can't do it. Following on from the case study, you do some classic bloods, your full blood count, you do a use and ease, and they come back. I asked a question earlier, can you explain why a 22-year-old man has had a stroke? These bloods should hopefully give you a clue. Can anyone pick out, maybe you don't have to go with the full diagnosis, but can you pick out what's wrong and what that might suggest first?
Also, I say this every week, but it's worth remembering they give you normal values in exams. So if you haven't heard it from us, you will get normal values in exams.
Yeah, chill. I think when you're on wards long enough as well, you pick it up, but there's absolutely no need to like sit down and study them. So what is abnormal here? Like, oh gosh, gone straight for the diagnosis. Strong, very, very good. Yeah, elevated HB from Nevada, good. Yes, and Jordan is absolutely right. It's polycythemia vera. So so here we go. You've got elevated HB. Your red blood cells are really, really high. And we'll talk about the MCV a little bit later. But this is polycythemia rubra vera. And it's a myeloproliferative disorder. You'll come across it in heme. But basically, a mutation in your bone marrow stem cells means you end up churning out loads and loads of red blood cells. The majority of this disease is caused by this JAK2 mutation. So often in the clinic, on the wards, if you suspect this, you'll send off for a JAK2 sort of mutation screen. But the clinical relevance of this is when you have tons and tons of red blood cells going through your vessels, it massively increases the viscosity of your blood. So it's much thicker. And therefore, because it's thicker and probably slower, you're more likely to have thrombosis. If you remember your Virchow's triad of stasis, hypercoagulability, and damage, I think. And if you have more thromboses, you're going to have more more strokes and pulmonary emboli and things like that. These are 2 random features. I can't quite link them to the pathology. It's probably just because it's slow going to your extremities, you get these things. But they're very, very classic for this condition. So if you see a patient who's really itchy after a shower, think polycythemia rubra vera. And same thing if they have sort of a burning sensation in their hands and feet. That's called erythromelalgia. The main way you manage it is actually just venesection. So you take their blood to try and reduce their red blood cell count. But often, and particularly in the elderly, people can't tolerate that because you're taking out so many red blood cells. They're having to constantly make more, so they become iron deplete and folate deplete and that sort of thing. So you often, if they're unable to tolerate constant venesection, you can offer hydroxycarbamide as well. And you'll come across hydroxycarbamide in heme, and it's basically a wonder drug for all things blood related. Now, can any of you pros, just kind of out of interest, can those blood be donated? That's a very interesting question. Anush, you're unmuted, so perhaps you can save me.
I have no idea. That's actually such a great question. I'm gonna find out though. I'll Google it.
Thank you, Anush, and thank you for that great question, Abetha. Yeah, can any of you pros tell me why the MCV is low? Think about, it's weird, but think about your anemias. What can give you a microcytic anemia? Iron deficiency. Really, really good. Yeah. So in fact here, obviously it's not an anemia because you've got tons of hemoglobin and loads of red blood cells, but because you're churning out so much red blood cells, you often become iron deplete. So you do have you're producing loads of red blood cells with a small MCV. So it's called a microcytic erythrocytosis. But yes, very, very nice. I often can't donate because of high viscosity, sadly. But yes, very, very good for you who picked it up. And don't worry if you didn't, this is a pretty niche condition in heme and you'll come across it later. But I will now hand over, oh yeah, we've done that. I will now hand over to Issi for management and investigations.
Okay, cool. Just take control. Hi guys, I'm Issi. So I'm going to go through kind of more of the sort of management and investigation side of stroke. So we're going to see some scans. It's hopefully going to be like interactive. So as every good SBA starts, a 78-year-old male, and I'm really sorry, there's so many fireworks going off outside my house. So if you hear those, I'm really sorry. So a 78-year-old man is brought in by ambulance to resus, and you're suspecting a stroke. What is kind of your first thing that you're going to do? And this is a classic SBA question. Oh, okay. So CT is like a good shout for a bit later on, but like always the go-to is like Dr. ABCDE. Like you're going to like stabilize this patient first. But CT is like a massive element of the management, like for sure. But in an SBA, kind of the single next step is Dr. ABC. So if we were going through some kind of main points, from Dr. ABC, what would be some things that we're going to look for, especially in a stroke patient? So they don't normally lose consciousness, they sometimes do. So we do still want to assess whether their airway is good. And that's always what you're going to start off with, because essentially in resus especially, you're not necessarily going to know they're having a stroke. You're going to want to assess their breathing. They've got any signs of kind of herniation. They're going to have pretty erratic breathing, and you're going to want to call in an anaesthetist. You want to get IV access for this patient, and also an ECG is quite a good idea in case there's an arrhythmia that's caused a thrombus in these patients. And then you're going to do your GCS, your AVPU score, which is like alert, verbal, response to pain, and unresponsive. So it gives you a really good indication of how stable your patient is very, very quickly. And then kind of, I think once you do acute medicine, you'll see that whilst that's all going on, another member of the team is reading through the notes to understand the medications. And the big ones they'll be checking for is if this patient's on an anticoagulant like warfarin that would make them more likely to have a hemorrhage. And one other thing to bear in mind, which I wasn't aware of before, kind of quite early on in year 4, was that hypoglycemia is quite a big mimicker and can cause like these motor and sensory symptoms and reduce consciousness. And if you think about it, that's a super reversible cause. And so you're going to want to do a blood glucose in these patients to exclude that. Cool. So what elements of the history in a patient would be very, very concerning and might indicate that they're having a stroke or something kind of major going on. There's kind of a few that were alluded to. Yeah, it's like sudden onset, hemiparesis, nice. Anything kind of past medical history, it's like previous conditions or anything like that that you can think of that predispose to stroke. Yeah, so previous TIAs, atrial fibrillation, it's like definitely a massive one. Yeah, polycystic kidney disease. Yeah, so you're basically going to want to look for these big red flag conditions. So if they've had a previous stroke or TIA, and that is quite a high possibility in stroke patients that they will have a second event. Cardiovascular disease, hypertension is one of the biggest risk factors, and it is kind of the focus of your kind of primary prevention of stroke is controlling someone's blood pressure. A known bleeding disorder or a thrombotic disorder. So you'll learn a lot of these in heme, but another example is in rheumatology is antiphospholipid syndrome, which causes arterial and venous thrombus. Also with big bleeds is that you can get raised intracranial pressure, which is obviously a surgical emergency and needs to be evacuated. So you're going to look for your papillary edema. But also, you know, these patients still come in and you've got to rule out an infective cause as well as to if they've got a reduced GCS. So they're going to assess all of these things as well. And yeah, a severe headache is kind of a massive headache is what subarachnoid hemorrhage patients will complain of. It's quite characteristic. It's a classic SBA kind of question, but we'll talk about it later. And then, yeah, the big one is anticoagulants. And so you're going to do precisely what was mentioned earlier by Precious. You're going to think about CTing them. So kind of back to the acute management, and this does come up in exams, is sometimes to do with the different scores that we use to kind of recognize a stroke. So there's one that's used in the community. You might have seen adverts for it. Does anyone know what it's called? You'll probably know it once you see it. Yeah, so it's the FAST score. And what does the FAST score stand for? And yeah, Rossier, you've smashed it. You smashed it. So I've given it away like instantly. But yeah, face. So is there any change in their face, their speech, any drooping? If they got weakness, and it's just it's just getting these patients quickly into hospital. And then Rossier score. So I've shoved them there for you to kind of go over like in your own time, but I think it's fairly like straightforward. So a few questions on back to the imaging. So why do we do a CT rather than an MRI in the acute setting? Yeah, so the big one is it's just quick, because the big thing that they'll tell you is like time is brain, and an MRI takes, you know, like half an hour, and also MRI compared to CT has kind of a few more contraindications. You know, you can't put someone in with a pacemaker, so it's a bit more complicated for our elderly patients. But out of the acute setting, you can use kind of more swanky stuff. You can do a carotid ultrasound to look for atherosclerosis. If you're thinking a cardiac cause, you can do an echo. So why do we image if it looks like they're having a stroke? Like, why do we need to look to kind of confirm it? What's kind of the main reason that we look for one? Yeah, so exclude hemorrhage, because if you start anticoagulating them, you're going to make it a hell of a lot worse. So yeah, we're essentially ruling out a bleed, but I guess, you know, if the history is a bit more hazy, you might be also looking for another cause, and a lot of malignancies can also bleed. And if there's been a history of a head trauma, or you've got a patient with like severe sort of brain disease and atrophy, you might be quite worried about different types of bleeds. So yeah, time is brain. I did not know this, but yeah, every 10 minutes, 20 million brain cells. Okay, so I took this from the NICE guidance. So I've also put a link to it in the notes of the PowerPoint, but I kind of jazzed it up because it wasn't purple and blue. But essentially, it's quite a nice, out of all the kind of pathways, it's quite a nice one because it's quite simple. So if it's an ischemic stroke, which is going to be at 80% of the time, you're either going to whip out the clot, which is, you know, only done in some centres. That's probably the thrombectomy is the best method, essentially. But otherwise, you're going to do thrombolysis, which is where you're dissolving it with alteplase, which is a plasminogen activator. And there's these certain timings that you need to know. So like 6 hours after the onset for thrombectomy and 4.5 hours within the onset of for thrombolysis. Something though to bear in mind is that with all of these treatments, it's all about if there's salvageable brain tissue. So some patients will wake up, you know, at night from a stroke and you don't really know when the stroke started. But if on the CT scan, it looks like there's brain to save, they'll just crack on and try and save it. Whereas if someone's woken up from a stroke and it just kind of looks like it was probably, you know, 8 hours ago, they might consider not doing these treatments. But like, you're not going to need to like worry about that as like at our level. And then everyone gets shoved on aspirin is kind of the go-to in the sort of long run as kind of secondary prevention. And then for hemorrhagic stroke, it's a kind of a bit more like there's not as much you can do medically apart from stopping any anticoagulating drugs. But surgical management wise, if there's any signs of hydrocephalus or any kind of midline shift, then you send them for a decompression or a shunting or burr holes into which I'll show you in a bit. It's quite cool. And so, yeah, in the long run, you'll probably learn this in GP. So it's a kind of classic, like UCL Lobes, you know, starting with the most basic stuff. So your lifestyle interventions, so diet, exercise, the compression stockings, and then you've got your medications. And the big onus is on blood pressure control in both of these types of patients. And then you've got some surgical things, which we're going to go over in a bit. Feel free to stop me if you have any questions as well. So with this guy, the 78-year-old, 3 hours after being given whatever the treatment was, they drop their GCS, they're unconscious, and the clinician, the consultant, decides to rescan this patient. And so what are some of the reasons why the consultant would think it's sensible to rescan this patient? What are they kind of looking for? It's kind of like simpler than you think, maybe. Maybe I've like worded it quite not very well, but so something's changed clinically. And so this is something that a lot of stroke patients are at risk of. And let's say that they had an ischemic stroke and I've just given them a massive dose of alteplase. Yeah, so it's called a hemorrhagic transformation. And so it's essentially where like either that your treatment has caused a secondary hemorrhage or just the nature of the damage to the vessel and the ischemia of that brain tissue has led to a secondary one. And so this can occur kind of, you know, hours later, days later. It's pretty bad. And so also you're going to wonder if there's been a, you know, a huge secondary event, another area of ischemia in the brain, or raised intracranial pressure that's happened later. So here, can anyone sort of tell me which bit is the kind of the ischemia, the initial like bit of ischemia? I like to think of this as sort of like a backwards egg kind of scenario, but maybe no one else sees that other than me. And so always imagine that you're looking from the patient's feet with CT head. So on the patient's right side, looks pretty normal. I'm not like a massive like radiology nerd, so I'm going to say that it's like normal. So yeah, on the left side, as you've said, it's the white bit is that area of like acute ischemia. And then the black area around it is just all hemorrhage. It's all like secondary transformation, which can happen. And then on the right, can anyone describe like what is actually present? Because the answer is kind of, I've already kind of alluded to, but perhaps like one of your consultants would ask you like what the kind of most obvious abnormality is, and yeah, it's the enlarged lateral ventricles, and this is, you know, sort of secondary hydrocephalus. And the reason that kind of strokes can do it is you've got this huge clot of blood, and then it draws water in by osmosis. And so you can get kind of swelling based from that, or the blood kind of leaches into the ventricular system and can just block the drainage of CSF. So there's a few like kind of interesting mechanisms as to why these patients get hydrocephalus. Cool. So what have I got next? Okay, so James was talking about them earlier, like the ischemic strokes in the territories. So I've thrown in a few scans, which I'm sort of doing one at a time, which maybe I shouldn't have done. But does anyone want to tell me, is this an anterior, a middle, or a posterior cerebral artery infarct? And can you tell me what side of the brain it's on? Or just give me I mean, I guess I've got the arrow, luckily. But just like, even if you can just say the side. Yeah, so this is like the right middle cerebral artery. So it's more lateral, as James was saying. And it's kind of frontal temporal lobe kind of area. Okay, and then how about this one? So this one's kind of more medial, frontal. Yeah, so it's like the left anterior. And then by process of elimination, what is this one? Yeah, on which side? Just to push you. Yeah. So it's the right posterior cerebral artery. So they might present with like visual problems, essentially. Fabulous. Right. Let's move on. So I was going to go over some sort of kind of big causes of stroke. So James has also talked about this, so I might just go a bit quicker. But I think sometimes it's easy to split conditions up into if there's an anatomical reason for it, an anatomical factor like an aneurysm or something. Hemodynamic, meaning that there's high blood pressure, which is very, very common. And then hemostatic, so problems with your coagulation. So either you've got low coagulation factors, or you've got like high risk of thrombosis. So I've got some pictures. So can anyone give me kind of recognize what the syndrome is or the factor is that kind of is increasing the risk of stroke in these cases? Some are more common in SBA land, some are more common in real life. And feel free to like have a stab at any of them. Yeah, so under hemostatic, there's sickle cell, and that's because it's, you know, the sickle shapes can get stuck in the blood vessels, and also they have pretty sluggish flow. And then yeah, so there's also infective endocarditis. We've got ospin to hemorrhages up there, so you're just firing off all these like infected emboli. And then amphetamines, yeah, so like cocaine was kind of what I was going for, but amphetamines do it as well. They just rush up your blood pressure, and you knock off all your atherosclerosis from your carotids into your brain. I don't know which one did you think was cancer? Because it's possible for some of them. And then atrial septal defect. So I put that in there because it can occasionally happen where someone's atrial septal defect hasn't closed, and a blood clot from the leg, which you'd expect to go from the lung, can kind of shoot up into the brain, which I've seen before, but I wouldn't say it would come up in SBAs, but it is like an interesting phenomenon, is someone with a DVT can have a stroke because it just moves into the left side and goes up. And so I think James had already mentioned polycystic kidney disease. So they'll have these big kidneys, their bury aneurysms, and their hypertension, and it'll burst. And then we've got our atherosclerosis, our cocaine, our amphetamines, sickle cell. Oh, wait, did anyone see it? So this rash is sometimes called, someone once described it as ground beef, which made me want to vom, but it's also called like lacy pattern, but it's essentially called livido reticularis, and it's present in like antiphospholipid syndrome, where they're procoagulable, and vasculitis. So when you're in room, learn this rash. And then, yeah, we've got our splinter hemorrhages, our patent foramen ovale, and then this was disseminated intravascular coagulation, which is essentially what happens in like meningococcal sepsis. It's that non-blanching rash, and basically their coagulation goes AWOL, and so they bleed a bit, they clot a bit, it just goes a bit all over the shop. So they can also present with strokes. And then just at the top, it just says like you don't need to know much about it for fourth year, but just consultants will always be impressed when you say obstetric causes. And so eclampsia is one, and also just pregnancy itself is a bit prothrombotic. And so you can get a combo of a lot of these factors at play. So often it's a bit of hypertension with a bit of high cholesterol that is the driver for stroke. So always just think a bit multifactorial as well. Okay, cool, guys. Sorry, my thing is really, there we go. Okay, so does anyone know, I think we did this in second year, I was thinking the other day, does anyone notice what the abnormality is on this CT scan? And I'm a bit like knowledgeable that I'm slightly going slower than I'd anticipated. Yes, it's an extradural bleed. So this is a bleed between the dura and the skull, and so it's just compressing that brain really hard. And so it is a big emergency, and you can kind of see the shape of it is quite harsh and kind of semicircular. And this will be the classic like bloke goes skiing, falls over or crashes, loses consciousness, then suddenly has a very lucid interval of being quite awake, and then will suddenly get a kind of sudden death. So if you're looking for a history that is suggestive, it'll be a sort of high level trauma and with loss of consciousness, and then quite a rapid recovery. And it won't cross the midline as well, just for bearing. Okay, does anyone know what this one is? I've chosen some pretty dramatic ones, so I think probably the left one is the easiest to kind of notice because the other ones are a bit ridiculous. Yeah, so it's a subdural bleed. So this is between the dura and the arachnoid. So it's kind of like a crescent shape. And so this will be classically in a sort of elderly person with a minor trauma. And then this one over here is, if you can see, you can see that it's like bilateral. It's like pretty impressive. So they can kind of have this insidious onset over a few weeks. They're kind of deteriorating cognition following a minor fall. So it's always worth noting that in elderly and if they're on anticoagulants. And in the acute phase, like on the left, they're very, very white, the bleeds, whereas in the chronic phase, they mimic more of the brain tissue and are a bit darker. So it's always like good to just have a look at the color. And so with subdurals, they do this like burr holing, which is like looks fairly grim, but apparently is actually quite minor surgery, and even quite unfit people can undergo it. And that is kind of the definitive management if there's poor cognition. And one thing to note as well is like, so with the subdurals, it's the bridging vein sort of between almost like the skull and the brain. And so if your brain's atrophied, you're kind of stretching those vessels and they're much more fragile. And they're prone to bursting, and that's why elderly people are particularly prone, is because our brains are kind of luscious and full. So we don't have those kind of gaps between the skull and the brain. So it would probably take a bit more of an impact to give ourselves a subdural versus someone who's elderly. Sorry, I don't know why I described a brain as luscious. Okay, if I give you this photo, does anyone know what I'm going to talk about? My flatmate pointed out that it looked a bit arachnoid. And I thought it mimicked what the kind of presenting complaint is of this condition. And I thought I was being really funny. Yeah, so it's like the thunderclap headache of. Everyone knows it. They're just like, go on, Izzy, just like crack on. So it's of the subarachnoid haemorrhage. So, yeah, you got it right. So these patients have basically bled between the arachnoid and the pia, so like right next to the brain. And they'll describe it as like the worst headache of their life, 10 out of 10 severity, sudden onset, occipital. They might have some nausea and some vomiting. They might have some visual disturbances. And some of them can also present just in a complete coma. It's that kind of bad. So it's a very, very like big emergency if someone has a subarachnoid. And so clinicians will act quite fast and possibly just transfer them to like the National Neurology Hospital if they're worried, because it is a kind of surgical intervention. But a good thing in the history for more stable patients is to ask about if they've had any headaches leading up to this, because they might actually have had these kind of warning headaches, quite severe headaches in the weeks leading up to it, which is probably like this minor bleeding that has kind of now come to a head. And so 85% are due to an aneurysm, but that doesn't mean that they've got polycystic kidneys. It's just that it's quite common for people to have these malformations in their brain. And the main risk factors really for it are kind of lifestyle ones. So smoking, alcohol, drug use kind of can just add to this aneurysm bursting. And then also what's quite good to ask in a history is if they've been doing sort of valsalvaring or heavy lifting, because that can increase intracranial pressure. I had one that did say they had been lifting weights at the gym. And a fun fact that will not come up in SBAs, and I just discovered today, is that another reason why they get sick is it kind of causes this neurogenic pulmonary edema in some patients as well. But like, you don't need to know that. It's just in case anyone was as confused as me as to why they get that. Cool. So on a CT scan, it's kind of this hyper intense signal in the subarachnoid, so always look for the kind of central portion of it. But kind of from the clinical history, you should have had a pretty good idea that this is like a possibility. And so the kind of main management really is just getting either coiling, so you kind of just insert loads of wiring into the aneurysm, or you clip the aneurysm off. But in the meantime, a lot of these patients, if left to their own devices, might be fine, but then the blood kind of irritates the brain and the vessels and can cause a secondary vasospasm leading to ischemia. So they often give them nimodipine, which reduces the risk of this vasospasm. So that's kind of more medical management of it. And then if they're nauseous and vomiting, you want to give them an antiemetic. Another investigation that they can use is a lumbar puncture. So CTs often sometimes can show like no signs, especially if it's been quite quickly after. So sometimes they wait 12 hours and do a lumbar puncture because they're looking for the presence of bilirubin, which is called xanthochromia. And so bilirubin is a breakdown product of red blood cells. So if there's been red blood cells in the CSF because of a subarachnoid, they'll have the presence of the bilirubin, and that can kind of give you an indication that a subarachnoid has happened. Cool.
I think it's quite interesting to note that CT is only good under 12 hours, and LP is only good after 12 hours, so you tend to use that in clinical practice.
Yeah, that was it. I was trying to think what the window was for CT. And then I just wanted to finish up about the management of TIA. So if the patient, their symptoms have got better, you've ruled out a stroke, but you think that they've had this TIA, all patients get aspirin unless there's like a massive contraindication for aspirin. So it's quite an easy one to learn for exams and to learn for life, is that the management is quite simple. They also, once transferred to a specialist like place, will get an MRI or some more advanced imaging. So on the right, there's some ultrasounds of the carotids to look for atherosclerosis. And then there's some sort of angiograms as well to look at the level of stenosis of the vessel, to then kind of plan for a carotid endarterectomy. So yeah, there's this kind of sense of urgency because we know that this is kind of a precursor to a stroke, and we kind of want to get the management down for it. And so a carotid endarterectomy is where essentially they'll open up the carotid, remove the plaque that's causing this stenosis, and it has to be quite a significant stenosis for them to do it. Now, I've put 50 to 99%, but most places will only do sort of 70% and upwards, and that's from some quite major trial data that's happened. For other patients, they might also just stent them if they're symptomatic, so there is some kind of leeway, but overall they'll only do this with a significant stenosis. And this isn't without a risk, is that once you're removing that plaque, if it's very unstable, you can send secondary emboli in. So the risk is small, but it is significant for a patient if it does occur. So my take-home messages. So I understand this has been a lot of info. I think to bear in mind is that stroke is its own specialty, and so it's okay to for it to be a difficult kind of concept to get around, and there's all the different types and all the brain areas. So I think just taking away the main points that the majority are ischemic and some are hemorrhagic, and to do a CT to differentiate between the two of them, and just have a look at that nice guidance in the flow charts because they are really, really well written. And just to see, through your modules, you'll get certain conditions that predispose to stroke. And I think if you just remember the kind of main ones as you go along, you'll be totally fine. So yeah, if anyone has any questions, let us know. But we've got some SBAs to finish up with. So I think we can load up our Menti link, right?
Yeah, so if you go on Menti, feedback before you do SBA. You can do feedback and then load up Menti. So it's menti.com. Code is 1937191. And we'll go on to the questions on the next slide.
There's only 2 of them, guys, so it shouldn't take too long.
Sorry for running a little bit late. Yes, please no good/bad. Please do let us know what's going wrong as well, because we do try and make things better. For example, the only reason we've done the next bit on Menti is because a lot of you asked for it early on. Right, enough of a plug. Let us, I would take control. Ooh, here's the Menti thing as a reminder. I thought I was controlling the slides, but I wasn't. But let's go on to SBA 1. So Mr. Shashikant is a 67-year-old ex-smoker with past medical history of epilepsy, atrial fibrillation, and type 2 diabetes. Presents with right-sided hemiplegia and complains of sudden onset vertigo, which started about 2 days ago. The nurses inform you that he's failed his swallow scream. And in A&E, this is what you see. What is the single best description of the pathology underlying this presentation? Mean question, I know, I'm sorry.
Sometimes a nice method is to exclude things are wrong. So even if you can get it down to 2, then it's 50-50.
This is a mean question because it's like a 3-stepper. You've got to identify the pathology, you've got to localize it, and then you've got to realize whether it's ischemia, infarction, or obstruction. So Give it a shot. No pressure.
Yeah, stroke questions are generally like this is like a very classic stroke question in exams, and like you'll get a few of these, but like these are definitely some of the harder questions in your exams. But like if you get this down, you're gonna get some of the harder questions in the exam right, which is like great.
So we've got 4 people responding. How many of you are in the call? 4. Are there 12 of you?
Also, if you're not playing along on Menti, that's fine. Just make sure that like you write down an answer or something. Like commit to an answer, because if you get it wrong, then you'll remember why you got it wrong going forward. Like so you don't have to go on Menti, but just try and commit to one in your head at least.
Half of them have responded. Should we move on or should we wait a little bit longer?
Up to you.
Can I post the responses? Hang on.
Take a screenshot.
Yeah. So these are the correct answers. These are the answers, and the correct answer is E. So what you were supposed to recognize with this question is that he has right-sided hemiplegia, but if you look at his face, he's got left-sided facial weakness, and that's the key sign of some sort of brainstem stroke. That rules out A because it's not to do with hydrocephalus. The next question is ischemia or infarction. I said 2 days ago, and it's still there. So it's less likely to be the sort of sudden onset quick recovery that you get in a TIA. So therefore, it's not going to be ischemia, rather it's going to be infarction. There's actual cell death. So that then narrows it down to D and E. I can see for the people who went for C why you went that, because you were thinking for brainstem and you thought anterior inferior cerebellar. The reason why it's posterior inferior cerebellar artery is because he's failed his swallow screen. I know that's like a sort of sly thing to put at the end, but failing his swallow screen is important. You do this in all people who come in with strokes. You assess whether they can swallow because you need to see whether they can tolerate having oral aspirin. And if they don't, that might be suggestive of dysphagia, and dysphagia is 9 or 10. So this is a really tricky SBA because it's making sure that you understand failing the swallow screen is dysphagia, and that's actually a symptom. The vertigo applies for both lateral mid. But well done for the majority of you, and well done for everyone who sort of had a go.
Okay, so this is my one. So you're an F1 who is called to a patient in resus with a suspected stroke. Airway management and IV access has been obtained. They are conscious and responsive with marked weakness on the left side, and their blood glucose is normal, and I hope that that is a normal value because I guessed it. What is the single next best step in the management for this patient?
I think that is normal.
It is normal. I had a bit of doubt just now.
Yeah.
Anything less than like 4 really is when we think hypos, I think.
Yeah. Also, while you're answering that, it's just worth pointing out that the last SBA is like a classic, like hard UCL SBA, because with some basic anatomy, you can narrow it down to 2 options, and then the 2 options that you've narrowed it down to, it's really hard to distinguish between them. So you might have narrowed it down to the 2 cerebellar arteries, and then it's really hard to pick between the 2. Or you've narrowed it down to either infarction or ischemia, and then you can't pick between the 2. That's like quite a classic UCL hard question way of formatting. James, have you been to the SBA writing workshop out of interest?
No, I just like making.
You're just good at writing. Yeah, fair.
There's an SBA writing workshop? No way.
Yeah, I'm going to one in the next week or so.
Is it run by UCL or is it like?
Yeah, as in it's run by the faculty. How many people have answered?
8. Should we go ahead? There's an interesting spread with this one.
This is also a really good question.
There we go.
I feel bad because I kind of alluded to it, but I didn't specifically make this difference.
I love that. It's
love
exactly 50-50.
So this is a really good thing to know, because when a consultant asks you which one to do, you'll know. So for bleeds, we prefer to use CT without contrast, which is also quite good because it's a bit quicker. You don't have to get the, put in the dye and all that stuff. I couldn't tell you specifically why you don't use the contrast. I think you can use contrast. Oh, you can. Go on then.
So basically, as blood clots, the how well it absorbs ionizing radiation changes. So you can see whether it's an acute bleed or you can see it's a chronic bleed. As soon as you put contrast in, it all goes white, so you will have no idea what kind of bleed it is.
Oh, smashing. Whereas we like to use contrast for tumours and also kind of some parasitic infections and like other infections. Guys, is there anything else that you would use with contrast?
No, basically anything that's highly vascular but isn't a bleed is the way you want to think about when you want to use contrast.
So the next time a consultant says, would you use it with or without contrast, you'll know. But yeah, it's yeah. I think Anush explained it really well, better than me. Cool. I think that's everything we had today. Does anyone have any questions at all? Even if it's about placement or modules, feel free. Otherwise, in the feedback, let us know what you want the next